Good morning, everyone, and thank you for joining us this morning for Dementia during the time of COVID. My name is Carmen Tellez with the Jewish Federation of Greater Los Angeles. Today's program is a joint event that's hosted by the Federation's Caring for Jews in Need Strategic Initiative, the Health Professionals Network, the Joint Distribution Committee, and my colleagues, Leah Phillips in LA and Mark Kodron in Israel. The Caring for Jews in Need Strategic Initiative at the Federation cares for those who are in need of a social service safety net. During the pandemic, the Federation has pivoted to meet the needs of the community, and it's worked extensively with our partners to make sure that the most vulnerable, like those who are living with dementia, are being cared for. And the Jewish Federation's partnership with the Joint Distribution Committee has enabled us to extend our delivery of critical support to the most vulnerable and create a Jewish community in Israel and around the world. Today's collaboration is an example of the ways that we can bring information and support all of our communities together. Some of Los Angeles resources include a call line to provide referrals and help for people that need to navigate the landscape of help during this time. We offer financial aid to those impacted by COVID, PPE for institutions, as well as for caregivers who are in the homes of survivors and seniors. We've also expanded funds being provided by our partner, Jewish Free Loan. Our loans, one of the loans that they provide is the Alzheimer's and Dementia Care Loan Fund. This is an interest-free loan that helps with the care of those that have Alzheimer's and dementia. We will post this information and other resources in the chat in case you would like to explore further. I just want to let you know that we will be taking questions from the chat. So during the program, please make sure to submit any questions that you have. We'll let Dr. Maaravi give his presentation, and then we will address all of the questions after the program. I will now turn it over to my colleague, Mark Kodron in Israel. Mark is the Director of Strategic Partnerships for JDC Israel's Eshel unit. JDC Eshel works as a social incubator, planning and developing services for the older adult population in Israel. Thank you, Mark.
Hi, good evening from Israel, and good morning to everybody in Los Angeles and in California. Just before we go over to Dr. Maaravi's presentation, so my name is Mark Kodron. I represent JDC Eshel's unit. We develop services for older adults to enable older adults to live independently at home within the community within Israel. Just to give you two words, this evening is a partnership between the Jewish Federation of Greater Los Angeles and JDC. JDC's work around the world is enabled through the strong partnerships it has with, amongst others, the Jewish Federation of Greater Los Angeles. And so on behalf of JDC, I wish to thank the Federation for its ongoing partnership and support in the work that we are doing in developing services in Israel for vulnerable populations, and the work we're doing in 70 countries around the world. But very briefly, JDC is over 100 years old and works in is a Jewish humanitarian organization working in over 70 countries around the world. Specifically around the world, meaning outside of Israel, we work developing Jewish leadership and caring for those Jews in need, those Jews who the weakest Jewish populations, primarily in second and third world countries. But in Israel, we work very differently. And in Israel, JDC works in social R&D. We work as an incubator, incubating new programs for vulnerable populations. Those populations, specifically youth at risk, the chronically unemployed, people living with disabilities, and older adults. And JDC Eshel, specifically the unit that I represent, deals with older adults. And just to give you an idea, very briefly as a context for Dr. Maaravi's presentation, I just want to refer you to the following slide, just as an idea, just so that you understand the way we work. So within JDC Eshel, we identified 3 key junctures in the aging process. The first being pre and post-retirement, the second being decline in functional ability, and the third being loss of independence. Today in Israel, there are approximately 1.1 million older adults, 80% of whom are independent, meaning high levels of functional, cognitive, and physical functional ability. Approximately 17% who have reduced functional ability, and the remaining 3% who live in nursing facilities, in geriatric facilities. And really, JDC Eshel is working to develop services, a continuum of services across these 3 junctures, client-centered services, models, to enable older adults to be able to continue to age at home within the community. And as we see here, 97% of older adults in Israel today live at home within the community. And with forecasts for a growing aging population, we want to enable that to continue in the same way. And how does JDC work? JDC is not is independent of the government of Israel, but our board of directors is made up 50% of JDC and 50% of 4 government ministries and the National Insurance Institute. So every decision that is passed in the development of our models has our government ministries, our government partners on board. And ultimately, once we've developed and we have reached a sustainable model, JDC Eshel can then phase out of the financial and operational responsibility of those programs and hand them over to our government partners to disseminate them throughout the country. So that's very simply the way we work. It now gives me great pleasure to welcome our guest speaker this evening, Dr. Yoram Maaravi. Dr. Maaravi is a senior physician at the Department of Geriatric Medicine and Rehabilitation of the Hadassah Hebrew University Medical Centers in Jerusalem, and a clinical research leader of the Jerusalem Longitudinal Study of Aging, a world-renowned age homogeneous cohort study of community dwelling elders started in 1990. Dr. Maaravi has been involved in clinical research on aging for over 25 years, including the physiology of aging, physical and cognitive functioning, and its relation to chronic disease and lifestyle, as well as technology and aging and human rights and ethics in old age. Dr. Maaravi has published over 50 publications on these topics. He has also served on many national boards on aging, including the government of Israel's Ministry of Health, Ministry of Welfare, National Security Institute, JDC Eshel, amongst others. So at this point, I'd like to hand over to Dr. Maaravi. Just to remind you, you can ask questions throughout the presentation on the Q&A, and we will present those questions to Dr. Maaravi at the conclusion of his presentation. Thank you.
Hello, good morning to you all. It's evening here. I'd like to comment on this strange time of virtual meetings. I'm used and experienced in presentations and talking to audiences in the real world, and now I have to adjust to the virtual world. It's not so easy when you don't see in the eyes of the audience whether they understand, whether you are interesting or you are boring. So I decided that I will choose the interesting option, and you will excuse me for sometimes being too enthusiastic. It's just because I assume that you like what I'm saying, and unfortunately you don't have the option to choose otherwise. So I usually present myself, and I will share the screen now. Share screen. Right. I was asked to share with you what we think we know today about COVID-19, the coronavirus, what we think we know about the proper way to deal with problems of dementia patients during this pandemic. And I will try to discuss and present a few topics that I think are important to understand the whole picture as much as I can. But I usually start with presenting myself personally and professionally, and then I will briefly discuss what we know, what we start learning about COVID-19. Unfortunately, we still don't know a lot. The important topics, I think, that has to be mentioned about aging and COVID-19, which I think are not really properly discussed in the media and also at the decision-making levels. And then we will talk a little bit about dementia, the biology of dementia, the diagnosis as is currently being used, and the future of early diagnosis. And the main topic that I was asked to touch, the behavioral and psychological symptoms of dementia and the problems they cause during this time. I'm married. This is the love of my life, Neta, and I have two daughters. They are both married, and I have one grandson, and I'm waiting for more. And I like hiking all around the world. This is on the summit of the Kilimanjaro, and this is the Himalaya. As you can see, I'm a patriot of my hospital, Hadassah. This is Patagonia in South America. And professionally, I've been board certified in 4 specialties: internal medicine, endocrinology and metabolism, geriatrics, which is the thing that I do the most with the most passion, and physical medicine and rehabilitation, which is the last. And when I was already chief of department, and I was asked by the Hadassah management to be ready to take care of a big department of geriatrics and rehabilitation together. Now, I have been fortunate during the last year and a half to advise and lead a program in the national TV that you can also access from Los Angeles through the YouTube of Channel 1 in Israel. The program was called 84, and it was an experiment of building a kindergarten inside a senior house, a nursing home. And we have been able to show that bridging the gap between the generations can cause great benefits to both old people and young. And this has become very popular in Israel and has enabled me to forward my ideas about aging and the proper aging that I hope to change in Israel. So I want to talk a little bit about COVID-19, coronavirus. Now, we have to be patient. You know, we are not used to wait for results. Nowadays, these generations, we want to get results immediately, but it doesn't happen like this, not in science and not in nature. It took us a long time to get to know the influenza virus and to learn how to live with it. It will take much shorter time, but still, it will take time for us to know everything we need to know about coronavirus. And there's still a lot we don't know. What we do know is that this virus is a respiratory virus, just like the influenza. It is more contagious than influenza, more lethal than influenza, but less lethal than its relatives, the SARS, which was less a problem as a pandemic because it was more lethal in killing people before they can infect others. So this is a problem because the virus is highly infectious and it takes time to present a major disease or unfortunately kill the host, and therefore it does spread more and more. These are the foundations of an epidemic. Now, the disease is usually a respiratory disease. The problem with the coronavirus is that some of the disease is caused by the virus itself, but some of the disease is caused by the response of the immune system of the host. And this is why some of the medications are dealing with our response, which is very, very profound and actually kills us just by our response to the virus. So this is what we call a cytotoxic storm of the immune system. And at the moment, there is no cure or no medicine that has been proven to effectively work or cure the disease, but we are progressing rather rapidly, I have to say, according to the timeline of science and nature. At the moment, we know that some medications that we have been using for many years, and they are very cheap, like a steroid called dexamethasone, can limit the immune response. Some other medications are being studied that will prevent the virus from entering the body and from entering the cells in order to replicate in them. And there are vaccines that you've probably heard in the media, but they will take, I think, at least 6 months to a year to show effectiveness and safety. And even though Vladimir Putin from Russia is claiming that they have a vaccine, their vaccine has not been through the stage 3 of the scientific research, like other vaccines, like the Moderna vaccine in the United States. So there are many vaccines, I think about 25, and only a few of them are in advanced stages, but it will take time till we have a vaccine. I think that eventually we will have medications, we will have vaccines, and we will learn how to live with this virus, just like we have learned how to live with the influenza virus, which has been one of the deadliest viruses in the history of mankind, and we still live with it, and we are not, there's no such panic about influenza killing more people yearly than the beginning of the corona. Well, now corona is more deadly, but we will learn how to live with it. Now, I have to comment about the relationship with coronavirus and aging. You know, everyone is talking about the fact that old people are at the highest risk. And very eminent scientists use statistics, and I'm not trying to diminish their expertise or their scientific merit. I just have to say that unfortunately, what we know as geriatricians is not common knowledge to other scientists. And if you don't know what we know as geriatricians, the science that you use is sometimes improper. What I mean is that we know that aging is very individual. I will start by saying that there is a lot of knowledge about aging that people don't know, and I wish to share it with you just in a few moments here. When people ask me, what is my profession, and I say I'm a geriatrician, one of the reactions is, oh, who are you? What a terrible profession. What can you do? What can you do to help these people? And the other comment is, you, geriatricians, you caused us to live longer, and what kind of life is it? It's not worth living. Well, I have to say, first of all, I think it's the most beautiful profession in the world. Aging is fascinating, and I enjoy every day, and I wouldn't like to see myself in any other profession. And I have seen, and I know a lot about other professions because I've board certified in a few of them. And I go every day to work, seeing stories and hearing stories that people usually pay money to go to the movies and buy books, and I see them and hear them and get paid. So this is the best profession ever. But the most important thing I want to share with you is that aging is much different than what people think they know about aging. Because over the last decades, we found that aging is improving all the time, quite rapidly. I used to talk about life expectancy, but when I teach students, medical students and other people, I now talk about life quality, because we have data showing that life quality is improving with aging. Now, you see these people here. I used to show these pictures as centenarians, people who are 100 years and older, as unusual people, but they are getting to be more and more usual. Look at this couple on the left. They are 108 and 102 years old, and they have been married 88 years, more than the average life expectancy. Now, this is the oldest marathon runner in the world. He's 107 years old, and he stopped running a full marathon. He's participating in commercials for diapers, even though he is continent, but he has to make a living. This guy climbed to the top of the Everest mountain twice, second time when he was 80. 20-year-old people die on the way up there, and he has managed to do it twice. This guy is the world champion cyclist of the 100 years and older. Well, he usually is competing against himself, but his results are similar to the 40-year-olds. This doctor is my role model. He died at the age of 105 and worked till his last day. And some of you may know Olivia de Havilland, the actress that has recently died at the age of 104. This is here. She is celebrating her 100th birthday, and here she is participating in the movie Gone with the Wind. So aging is changing rapidly, and you see among you and around you 90 and 100 years old that are much healthier and better than their previous generation at their age. But the very important thing I want to share with you about aging and the coronavirus, aging and the risk for coronavirus disease and dying from coronavirus, is that aging is very individual, and we age differently. And the variability, the change from one person to another is getting larger and larger as we age. Now, I want to show it briefly in just two or three slides. Now, I'm quoting a colleague of mine, Des O'Neill, a geriatrician from Ireland, from Dublin, that says that we are born copies and we die originals, meaning that we are very similar when we are young, but we are very different when we are old. And the reason is that because everyone ages differently. Now, I apologize, this is in Hebrew, and this shows at the age of 20, 3 individuals who start very high up with the functioning of their different body systems, like the brain and the heart and the muscle. At the age of 20, they are very similar, and they have much reserve above the critical level of reserve. But when we age, the rate of aging and the rate of losing function of various systems is very individual. And you can see by the age of 65, there's a big difference between these 3 people. This woman is aging more rapidly than this one, and the systems are different. It causes them, at the age of 85, there's a bigger difference, and it goes on like this. Now, if this is the basic of aging, how can we refer to 85-year-olds as one person, as they are all in the same risk, at the same risk from coronavirus? We know it is not true. The problem is that the statistics and the science does not collect data on the relationship between functional age and the risk. Only between the chronological age and the risk. And the chronological age is not a good indicator of aging, as we can see here. So my claim, as well as my colleagues in the United States, is that we need more data to show, but we know from a lot of research that there is a big difference between a healthy 85-year-old and a very dependent 85-year-old as related to the risk of coronavirus. And it means that not all old people are at the same risk, and not all old people should be as careful and as to lock down themselves as young people. Now, this is very important because the risk of lockdown and social isolation is real, is high, and we have to know it. So it's not something that you can just by the fainted decision you decide that everyone should stay home inbound and not go out without any consequences. So we have, and I have suggested to our government in Israel to build an index of dependency and independency as related to the risk of coronavirus in old age, and to address all the caution and the reduction of risk to those who are really in higher risk, which are the ones with physical dependence, cognitive dependence, and comorbidity. The others are able to live as young people live and should not be put to social isolation because it has major consequences. And this brings me to the consequences of social isolation. Now, as I said, the risk of COVID-19 in old age is related to frailty, the loss of function, physical dependence, dementia, and comorbidity. We can see this is data from the United States showing that the majority of death mortality in the United States came from long-term care facilities, more than 50%, some places more than 80%. This is true also in Europe and in other places, and in Canada, it's much higher than that. Now, the social isolation and the lockdown has major risks for old people. We know that loneliness can cause people to be more sick. It can cause people even to die. And there are data showing that lonely people have an increased mortality risk of 30%. We know that social isolation is very detrimental to old people's health in relation to physical function and relation to cognitive function. And this brings me to dementia. So I will try and I see that I have to stick to the schedule. I will try to talk about a few topics of dementia that we need to know. We have apparently haven't been so successful with dementia because we have been studying dementia for many years and we still don't have cure. But I think that this is not a proper way to present what is happening, what is really our progress. And I will try to show you that we are learning more and more about dementia, and we are making real progress that will enable us to find cure to this disease, this terrible and devastating disease. To find cure, it will take time, but we are really making progress, and I will show you which progress. Now, it is important to know, okay, it is important to know that at the moment, diagnosis of dementia is rather late. We know that dementia is a disease that takes many years to pronounce itself. It's been there for 10, 15, sometimes 20 years before we pronounce the cognitive changes. It's been in our brain for many years. At the moment, our diagnosis is a bit late. We are able to diagnose a patient or a person only when his cognitive function is deteriorating. But the big progress is that we have been able to devise diagnostic technologies and expertise to find the people who are starting with the disease even before cognitive function is affected. And this is the major revolution in the study of dementia. At the moment, I have to say that when Obamacare was still effective, I don't know how it is today with all the politics, but one of the issues in the Obamacare was the annual wellness visit, including a mandatory cognitive evaluation for elderly people in the United States. And the GSA, Gerontological Society of America, and the Alzheimer group and the American Geriatric Society, they sat together to decide what are the best diagnostic tools that are very simple, very quick, but reliable. And there are two simple and efficient diagnostic tools today that are recommended and should be known and used. These are, as you can see with the bold X's here, these are the AD8, Ascertain Dementia, which is a questionnaire, and the Minicog, which is a test that you do very quickly. Now, the AD8 you can find on the internet. It has 8 questions about changing of cognitive functions during the last time, and it's usually given to the relative or the primary caregiver that is accompanying the patient with suspicion of dementia. The other one is the Minicog is very simple. You ask the person to repeat 3 words, to recall 3 words, and after you tell him the 3 words and you ask him to repeat it, you ask him to remember it, then you ask him to draw a clock drawing test, which is like this. And then at the end of the clock drawing test, you go back to the 3 words. Repeat after, now tell me what were the 3 words. Now, if he recalls the 3 words, there is no dementia. When he doesn't recall any word, there is dementia, and it doesn't matter what the clock showed. If he remembers only 1 or 2, then it does matter what the clock shows. If the clock is normal, completely normal, like here, okay, where you have all the numbers and it shows the time you asked him, then there is no dementia. But if the clock is abnormal, even by 1 number not in place, then there is a dementia. This test, very simple, very quick, it doesn't take much time, turns out to be as reliable as other tests. These tests are the current one. They don't help us find someone who is in the beginning of the disease, because when people pronounce the dementia at this stage, it's a bit late. This is why excuse me. This is why we haven't been able to find a cure to the disease up till now, because we gave the medicines that we developed to people who already have advanced damage. The possibility of curing a disease is only when you start treating people at the beginning of the disease. We haven't been able to find these people or detect the disease at its beginning until recently. During the last years, we have found ways to diagnose dementia a decade or two before it pronounces itself as cognitive deterioration. Now, there are a few tests. I will briefly, this is not the topic of our presentation, of our meeting, but I will briefly show it. One of them is a very highly sensitive, qualitative MRI, which shows the atrophy of the area of the hippocampus, which is the first organ in the brain to be affected by Alzheimer's disease, also responsible of the immediate memory, short-term memory. This is one test that you can find changes even a decade or more before the change of cognition. Another test is a PET scan that shows the accumulation of the damage of amyloid, which is one of the proteins that is present and may be responsible for the damage in the Alzheimer's disease. And you can see that there is no damage in normal people, some damage in mild cognitive impairment, which is an intermediate state, and Alzheimer's disease has a profound damage. Another one is also another compound of amyloid, where you can see that accumulation is high. Both all these tests, and the last one is a test that you measure the levels of proteins, markers, beta amyloid and tau protein in the spinal fluid, which show that these proteins are either low or high according to whether they accumulate in the brain and therefore they are low in the spinal fluid, or they are discharged from neurons and therefore they are high in the spinal fluid. Combining these tests, and there's another one, the last one is a very, very sophisticated and very hard memory test developed in Cambridge in England, Cantor-Pal memory test, that shows changes in memory in a normal, apparently normal person a decade before dementia appears. Combining all these tests together can diagnose a person with future dementia a decade and a half or 2 decades before the disease. Nowadays, with these tests that are not yet readily available to the public, but they are available to the science, they allow us now to find the people to receive the medications in research and studies that will show which one will be successful as a cure to the disease. This is the big revolution. Now, since the disease takes a while, as I told you, a decade or more, it will take a decade or more till we have a cure. But we are much closer to a cure than we were before we found these diagnostic tests. So now to the problem, I think that the problem that causes everyone to fear dementia more than anything else. I think dementia, according to studies and surveys, is feared by most elderly people more than death. People would rather die than live with dementia, and rightly so. It is a terrible disease. I've been a physician taking care of people dying from different diseases for more than 3 decades. And I have treated patients with all terrible diseases and tragedies, but I have never seen a disease so devastating, a disease that actually robs you of your personality, of who you are. And therefore, it is truly a disease that we must find a cure to. And the biggest problem with dementia is not the loss of cognition, loss of ability to think properly. It's mostly the behavioral and psychological symptoms of the dementia. The change in your behavior, the fact that you become aggressive, the fact that you have sexually abusive behavior, and all sorts of things, refusing to cooperate, refusing to take a shower and to eat. These things are emotionally and physically exhausting and taking a lot of energy of families, and they are tearing your heart, and it's terrible. So what do we know about these things, and what can we do about them? And what can we do about them nowadays when we have the coronavirus, and we are told that people with dementia are at risk, truly, and should be careful not being in contact with other people. So this is the thing I want to discuss now, and the last part of my talk, about what is Bpsd, behavioral and psychological symptoms of dementia, what can we do about them, and what can we do nowadays with people with dementia in order to improve their quality of life and reduce the risk of corona at the same time. Now, Bpsd, I will use the abbreviation. Bpsd is a short phrase for a lot of problems of demented patients that everyone familiar with dementia or living with someone with dementia or knowing someone with dementia should know part of them. It's the calling out, the aggression, the agitation, hallucinations, delusions, wandering. You're trying to get up and go to work, even though you have been retired for 30 years. Depression, or the opposite, elevated mood. Sundowning, the fact that you become confused when the sun goes down, and increased agitation in the afternoon or evening. Problem with sleeping, insomnia, lack of motivation, anxiety, resistant or unease towards carers, intrusive behavior, inappropriate sexualized behavior, which can be very difficult for families when it's someone you love, inappropriate urination and defecation, terrible things, and inappropriate social behaviors. All of these are under the diagnosis of behavioral and psychological symptoms of dementia, Bpsd, and we should know how to deal with them, which is not easy. Now, first of all, it's very important to know that old people, and people with dementia included, are taking many medications. And we know that medications can have profound negative effects on our brain and the brains of demented patients. So we should always be careful about the medications they take. I'm not going to read all the medications in this list, but it's very important to review the medications with an expert and see whether any of the medications that our relative with dementia is taking in order to reduce the problem of Bpsd. Another important topic is to be sure that there is no medical condition that aggravates or even causes the Bpsd. Now, they can be suffering from pain without being able to express it because of the dementia. They can have infection, they can be dehydrated or have a problem with electrolytes in the blood. They can be constipated. They can have urinary retention. They can suffer from anxiety or fatigue, have hearing and visual problems, or problems with their teeth. All of these can have profound effects on Bpsd and should be addressed and cured. Now, one very important diagnosis to be differentiated from Bpsd of dementia is delirium. Delirium is an acute problem which causes the same symptoms, but it's an acute confusional state that is always related to an organic problem, like an infection or a metabolic problem or a medication problem, and it can even lead to death if you don't find the cause of the delirium. And delirium is different than other presentations of dementia. These are the 4 manifestations of delirium, the diagnostic criteria, and you need 2 of them with one of the other 2. Acute onset and fluctuating course. It suddenly appeared during the last day, hours, or days, and it's better during the day and worse during the day. You have fluctuations, and there's a big inattention problem. You can talk with someone, he can listen to you, can talk to you, and then flies away. And another one is disorganized thinking or a change in the level of consciousness, either very, very agitated or apathetic and hyperactive. If you have these criteria, then you are dealing with a delirium, and then you should be very alert to the possibility that there is something grave that has to be found and dealt with. And this is not Bpsd. So this is important to know. Another one of the differential diagnosis that it's important to know is depression. People with dementia, at least during the early stages, are aware of their situation. And it's very common to develop depression related to the understanding that you are suffering from dementia. And I present here the easiest and yet reliable way of diagnosing depression by asking 2 simple questions of the person who is supposed to be suffering from depression. Over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, or feeling down, depressed, or hopeless, okay? And you can see the relation to the answers and the probability of being in the depressive mood. So if you have 4 or more, this is indicative of depression. Now, many patients who are agitated and wandering and suffering from problems that or aggressive, that it's very hard to deal with, sometimes we don't have a choice but to use medications, mostly antipsychotics. But it should be mentioned that antipsychotics are not first line, they are always second line. Always try and use a behavioral approach to address the problems, and only if you fail, then go to the antipsychotics, because antipsychotics are also very dangerous and harmful to the brain of old people with dementia. Of the antipsychotics, the one that has been proven to be relatively safe is quetiapine, or Seroquel as we call it here in Israel, but quetiapine, relatively safe to the other medications, and we use it preferentially to the others, but not preferentially to behavioral responses. It should be mentioned that if someone is suffering from dementia that is called Lewy body dementia or dementia-associated Parkinson's disease, giving antipsychotics is forbidden, because this can cause what we call a neuroleptic malignant syndrome and can cause a real danger to the patient and should be avoided at all costs. Now, I will just use 2 examples of behavioral problems of dementia that are common and cause lots of suffering, and how they can be ameliorated or addressed. One is the wandering and the fact that you are getting out of the house and getting lost. Many people are very, very distressed. You cannot leave your grandmother or mother for a minute because you are afraid that she will get up and get out of the house and lose herself or even be hit by a car or another thing. So you are constantly anxious all your life and you don't have even a minute of ability to leave her and go somewhere. So what can you do to address this problem? First of all, it's been found that if you place a mirror on the wall, on the door, a mirror on the door reduces the getting out of the house by people with dementia from 76% to 36%. It was measured by the touch on the handle with a sensor. You can also place a photo of the patient, the person, or yourself. You can put shutters on the door and it will look like a window. You can take the people with dementia on regular walks outside and reduce the need for wandering, reduce the daily aggression with yourself or with a volunteer. And you can also record a family's member voice, which always causes some reduction in agitation and relaxes them, okay? These are simple solutions that can be used by everyone. However, the fear that they will get lost is real. And there are many devices nowadays to be able to locate them if they have been able to get lost. We have sensors, GPS sensors in watches, in the soles of the shoes, and in other devices that you can use in order to be able to detect them and make sure that you don't lose them and be so afraid. Another major problem is the eating problems. It is very common for people with dementia to get to a stage where they refuse to eat. It's not necessarily that they are not hungry, but it's a behavioral problem. Mostly they are not hungry, but sometimes they are confused and it gets very hard to make sure that they eat properly. And it's not only a Jewish tradition that food is important. Oh, you eat, you're healthy. That's what my grandmother used to say. It's a universal problem. And we believe that food is life. Although in advanced dementia, we found that it's not always true. But in earlier stages of dementia, it's very distressing to see that someone refuses to eat and spits and makes problems. So we can improve the eating habits by some behavioral changes. First of all, try to avoid confusion, okay? Use routine. Eat always at the same place and the same time. A familiar table, familiar time, it makes for more orientation. Try and use a relaxed, quiet environment for dinner or breakfast. Close the radio, close TV, close all distractions. Use something to make contrast for the plate and the food on the table, because it's very easy to get confused when you have dementia. So it has to be very clear with a contrast. So you see in the example here where you put plates with contrast that you can see properly. Serve the food one plate at a time, not all the food on the table as we used to, and use simple and clear instructions. This helps. Now, last advice I can give in order to improve cognitive function and in order to preserve what we call cognitive maintenance to people with dementia, I think it's also true to people who are healthy, are these four things: physical activity, social engagement, intellectual stimulation, and music. Physical activity is important. JDC Eshel has produced booklet. I'm not sure whether it's translated to English. They will tell you nowadays for addressing dementia during the coronavirus epidemic. And there are instructions on some exercise to do in the house. But exercise is very important for our brain and for dementia. All sorts of exercise. Social engagement, critical. It's a problem now when we try to isolate people who are at risk. So we have to find solutions to this social engagement. But social engagement is very important. You see here pictures. These two pictures you see are my medical students that attend a daycare of people with dementia in Jerusalem. And the social interaction is very important to people with dementia. Intellectual stimulation is paramount for cognition. If you want to avoid dementia, stimulate your mind. Stimulate it as much as you can, and not just by solving crossword puzzles or Sudoku. The best stimulation is learning a new instrument, musical instrument. This is highly challenging. Also, learning new language. You know, there's a new, not so new application, Duolingo, that is very easy to use and learn new language. So these are intellectual stimulations on the high level. And music. Music is the most powerful tool for our brain. When we lose our mind, the last thing affected is music. Music sits in the base of our brain and is related to more parts of the brain than anything else. I would recommend that all of you find this documentary movie that is available on YouTube. It's called Alive Inside, an amazing movie showing the effect of music on people with very advanced dementia as well as earlier stages. Music has the power more than anything else to change our mind, and therefore it is important. We have, I'm very proud of my colleagues in Israel that devised and invented this application called Together. You can find it on the Google App Store and Apple, the iPhone and Apple stores. Together, using music to connect the people with dementia with their family and to connect them with the music. Music is very powerful. The last thing I want to say, if we want to combine these things, physical activity, social engagement, and some sort of normal living to stimulate and keep the mind of people with dementia, at the same time of protecting them because they are at risk from corona, we can use what we started here in Israel, and I am proud to have been an advisor of this project. I'm sorry, this is in Hebrew, but I will explain. This is the local, all the municipalities in Israel are part of this. We devised a safe space. This is the name of the project. Every municipality designates certain parks and streets during certain times of the day, at least from 9 in the morning till 11, and we close these parks just for old people and those at risk, and prevent from other people to come there and increase the risk. Therefore, they can go out, meet people, engage in activities, have card plays, listen to lectures, listen to music, have a normal life, at least for a few hours, instead of being isolated at home, and still be protected from the disease. So this is one of the solutions. We have many digital and virtual solutions to meeting and social engagements. We have to use everything we can to protect people with dementia. So in conclusion, I want to point that generally, I think I'm very optimistic about the future. I think that we are learning more and more about COVID. We are on the way to find a vaccine, and we will learn how to live with it as we learned how to live with influenza, and we shall overcome it. I'm also optimistic about dementia because of the early diagnosis is enabling us to find cures and to hope for cures in the near future. And I'm also very optimistic about aging because, as the Beatles have said, it's getting better all the time. So I will conclude here. Thank you very much for your patience and attention, and we will try and answer the questions.
Great, thank you, Dr. Maaravi. That was a very informative and very inspiring presentation. Just to ask if you still have questions and you would like to pose them to Dr. Maaravi, please write them in the Q&A. We still have a fair amount of time for Dr. Maaravi to answer the questions. I will just pose one or two that we do have here in the meantime, and I see the one related to this last point you just made. You just said that we will learn to live with it like we learned to live with influenza, Dr. Maaravi. And the question is that this is not a life. Must we stay locked up until the virus is eradicated? The younger people are wearing masks and using social distancing and seem to be carrying on with their lives. Yet we older people, are we doomed to years of isolation? This is not a life being afraid of a virus and living freely. Is this paranoia justified?
As I said, you have to separate the ones that are at high risk from the rest, okay? The ones that are at high risk should be careful. No need for any paranoia. Secondly, as time goes by, we learn more about the virus. We also learn more about the immunization of those that have healed from the disease. Now, we still don't know exactly how much the virus infects people well and who are the contagious one. Young kids, a young elderly, and so forth. I think that what we will see during this coming months and year, maybe, is the accumulation of knowledge and reduction of the paranoia and fear. We will start seeing people getting back more and more into normal living, as we will see more and more people who are immune, and we will have the vaccine. I think somewhere between 6 months and a year, the first people to receive the vaccine will be the ones at risk, just like with influenza, which is mostly those elderly at risk that I think they have to be careful. They will be the first ones to receive the vaccine. So I think if we know more and more how to protect ourselves and more who is at risk and who is not, you will see more and more, even old people, being able to go outside, to live normally. You will see more and more projects protecting the ones who are at risk and still being able to live some normal life, and things will improve. You have to unmute yourself.
Thank you. And there's another question here related to palliative care and end of life. I'm concerned that my spouse with dementia or I may pass away from COVID. How do we prepare for this and ensure our wishes are respected?
I haven't touched the topic of end-of-life care and palliative care in dementia because I couldn't cover everything. It's a very important topic, and I think it's one of the neglected topics of care of dementia. We we forget to let go. We don't know how to let go. We don't know how to ask personal wishes and preferences when it's relevant. I think that there is no difference between this time of COVID and any other time relating to the end of life of dementia. The end of life of dementia has to be dealt with as the end of life of every other disease. Now, I know that there is a big debate in many places. It started with allocation of services when the healthcare system is overwhelmed with a pandemic and whether to allocate them to old people or not. I think that if you discussed and decided that you don't want life-sustaining procedures or anything else, it should be clear to all healthcare professionals that this is your choice and it should be discussed in advance. The problem with nowadays, you know, when you diagnose someone with corona, you isolate them, you put them in, and when they are sick, you put them in intensive care units and no one is allowed to come and visit them, which is terrible. Seeing someone die without a human touch of the family is terrible. I think that if you are living with someone with advanced dementia, you should make sure that they are not admitted to such a facility, so you will be able to go the last steps with them.
Great, thank you. Does doing puzzle and mental games help prevent dementia?
There's no clear answer to that. There's conflicting research on it. I think it's better than doing nothing, but I think that qualitatively it's not stimulating enough. You know that in order to preserve your brain, you have to challenge it, but you know, like if you are walking half a mile and if you are running 10 miles, it's a big difference to your exercise. The same thing implies to the brain. You should try and stimulate it as much as possible. At the same time, doing it in an enjoyable way, okay, not to suffer. So if you enjoy puzzles and crosswords and everything, it's better than nothing. But if you can go and study something, learn something, and do it on an increasing level, it's best for the brain.
Thank you. So Paul says, my mom wants to sleep a lot. She's 90 years old. She says she's happy in her bed. How should we be handling this? She says, why shouldn't she be sleeping? She's happy in her bed.
Well, you know, it's the answer depends on her health and other conditions. Usually, I think sleeping is very important. Most of my patients complain that they can't sleep. Okay, so if someone can sleep and enjoys it, I think we should give them the joy of sleeping. At the same time, it's important to make sure that they are active and stimulated and keeping their body active, keeping their function. But if you can balance this and still sleep 10 hours, 12 hours a day, and at the other hours being able to get up, walk around, meet people, talk to people, then I think it's okay.
Okay, thank you. What symptoms and behaviors are indicative of Lewy body dementia? Bye-bye. pronounce that.
Lewy body dementia is a type of dementia that is very similar to Parkinson's disease. These people have dementia with what we call extrapyramidal symptoms. They have this stooping gait and shuffling gait with small steps and walking, bending with stiffness and very slow actions, very similar to Parkinson, with a dementia that is similar to Alzheimer's disease, but different because of the related gait and activity and function. This specific type, it's relatively rare. It's not as common as Alzheimer's disease. This specific type is very sensitive to these medications, but it's relatively easy to diagnose because of the presentations of a Parkinson-like disease.
Okay, thank you. What is your view on the use of omega-3? Does daily consumption of this pill help prevent or reduce dementia?
As far as I know, it doesn't. I know there have been studies, and I know the literature is flooded by studies on nutritional supplements and everything. I know about ginkgo biloba and omega-3 and everything. I have to say that I've been following the research on nutrition for many years, and I'm active in committees in Israel. No nutritional supplement has been proven to be effective in dementia. No one. And I can tell you, some studies show it, but the studies are not valid enough. However, nutrition is very important for dementia. Food itself, not the supplements. So if you want to keep your mind healthy, and if you want to stay healthy, whether you are young, whether you are old, whether you already have dementia, try and eat a Mediterranean diet with lots of vegetables and fruits, with olive oil, with garlic, with fish, with these are the ingredients. Also very important, red wine, chocolate, not milk chocolate, dark chocolate, and coffee, lots of coffee. All of these have been found to be healthy generally, healthy for aging generally, and healthy for dementia.
Thank you. The question is, are you familiar with primary progressive aphasia, the semantic variants, and how does this impact everyone? PPA.
Well, it's a relatively rare disease, as far as I know it. It's one of the variants. I'm not very familiar with it. I'm a geriatrician, not a neurologist. I deal with dementia and less with the specific, relatively rare variants. So I don't want to answer something that I don't feel confident about.
Okay. During COVID, I find there can be times when my attention span is less than usual and I get Zoom or virtual online overload. Is not using my mind in the same way that I did before COVID, would that perhaps make one be more at risk for getting or bringing on dementia?
I'm not sure I understood the question. Overwhelming of the communications now?
It sounds like the person is less stimulated. Could be referring to sort of deconditioning, less stimulated, use their minds less than they did than prior to COVID. Yeah, and the fear is because they're less stimulated now that may bring on dementia later on.
Well, it's not necessarily bring dementia, but keeping your mind stimulated is important for everyone. Not necessarily that if you're not stimulated, you will get dementia. It's much more complicated than that. But I would strongly suggest everyone to try and keep stimulated. Read something, watch movies, learn something. Possibilities are available now even more than before.
Okay. My question is in regards to personal hygiene. We have a hard time getting our mom with dementia to shower. She also tends to wear the same clothes for days. She gets feisty and upset when we tell her to shower. We've come to realize her condition is getting worse. She's now forgetting or is confused in finding the restroom and a bedroom. What recommendations can you give us?
It's a challenge, definitely. From my experience, the best way to approach this is to be very flexible and to try and, we have this saying about coping with dementia and refusing to cooperate. We call it TADA, T-A-D-A, TADA. T is tolerate, A is anticipate, and DNA is do not agitate. So you have to try and flow with them. You don't want to go to the shower. Okay, when do you want to go to the shower? I don't want to go to the shower. Okay, let's try again in the evening or in the morning. You try to negotiate and find a time. So she will not take a shower every day. She will take a shower once a week. But you will find a time that you are able with everyone has their own different things that stimulate them or attracts them to do something. You have to find and be very flexible in order to do it. Sometimes you won't be successful at all, and you will have to live with the fact that there is no hygiene and no shower at all, as we have to accept the fact that in advanced dementia, people refuse to eat and they don't eat nothing at all. This is part of the disease sometimes, and we have to accept it that we will try and find solutions, but sometimes it may be impossible to find a solution. My suggestion is to try and go with them and try to accommodate their wishes, as strange as they are, and try to find the times that they do agree to take a shower. 2 o'clock in the morning, okay? Try and go with them and not agitate them. Okay, tada.
Thank you. What can we as caregivers of a spouse with dementia do at home to look after ourselves, both physically and emotionally?
Very important. We do have some voluntary groups here in Israel, and I'm certain that you do have them in the United States as well, that you have some support groups and you have some activities for the caregivers, because caregiver stress and caregiver burden is very, very dangerous, and you need to be strong and healthy to take care of your spouse or your family. So you should be able to have someone to help you, relieve you, get some free time and activity, go to any activities of the support groups or to the community centers, or everything that you can have some time for yourself. We have in Israel some departments that you can put your loved one with dementia for a few days to take a vacation, to go in and recharge your batteries. You have to find ways to get out and relieve yourself from the stress.
Okay, thank you. So thank you for such an important, informative program. My father, who's 95, crashed 1 month after his retirement facility invoked isolation protocols and went from his own independent apartment to an assisted living facility where he is locked in, eats alone, gets out only for short walks, etc. He has no comorbidity other than his age. How can I, his daughter, best support him right now?
Now, we have the same problem here in Israel. I don't know, it's so complicated because when you are in an assisted care facility, the management, which I think that in most cases they feel that they are alone in this struggle, they impose the strictest rules on the elderly patients in order to avoid any risk to them, at the same time increasing the risk of losing their dependence and their health. And it's terrible. Even here in Israel, I'm a member of a coalition of human rights groups addressing the government to impose those facilities to give some permit to families to visit and to let these people go out, because you can keep them safe and yet let them get out of the place, because usually these facilities are relatively protected. You do tests for corona for people getting in, so you can make some form of social engagement inside. If you are facing a facility that does not allow this, I don't know what are your options. You can take them home if it's a possibility. Otherwise, if you cannot fight the management legally or otherwise to let people get a little bit exercise and go outside of their lockdown, then I don't know what to suggest. I know from my experience here in Israel that many cases that have, the families have struggled against management, they have been able to change the policies.
Okay, thank you. Can you speak more about the kindergartens in the skilled nursing facilities and the difficulties as well as the benefits?
Well, the reason that I am very active in it, and I'm very active, now the corona has stopped me a little bit or delayed me a little bit, but I believe that a healthy society is a multi-generational society, as it used to be. Kids growing up with old people beside them, growing up knowing that old age is part of life and normal and what to expect. It doesn't happen today. It used to happen a century ago. Now, in order to build a healthy society, in order to build young kids knowing to respect aging and to address aging properly and not to be ageist, we need to get them together. Now, one of the solutions is getting kindergartens into places where old people are there. It can be in nursing homes, it can be in the community. It can be in kindergartens themselves or in school. And so this is the project that I'm active in Israel. I'm now collaborating with almost all the major cities, Jerusalem, Tel Aviv, Beersheba, all the municipality management in the kibbutzim, 257 kibbutzim in Israel. We are trying to build intergenerational kindergartens, okay? Also on a private level, there's a project. Now, when you get them together, it takes a while for them to open up. Doesn't happen immediately. So visiting once a week or once a month is not good enough. It has to be intensive in the beginning. That's what we have been able to show in this show, and I recommend that you look it up, 84 in Israeli TV or on YouTube. It took about 2 weeks of a daily 4 to 5 hours activity. Only after 2 weeks that especially the elderly people opened up. They didn't open up. They were very close and cautious whether they will be hurt again by young kids coming into their heart and leaving them afterwards. So it has to be intensive, it has to be patient, and then when you start knowing each other, you start seeing amazing things. We have been able to show that the old people improved in function, in mood, in cognition, during only a short time of 6 weeks. It was amazing to see their grip strength, their physical strength, their ability. You should watch the show.
Yeah, I'm familiar with the show. Dr. Yoram Maaravi, thank you very much for a very informative, fascinating presentation, and thank you for sharing your insights and your knowledge. It's been excellent, and from the feedback that I've seen, it's been highly appreciated. Earlier you mentioned the booklet that JDC Eshel created with the Ministry of Health. For those of you interested, it's Dementia in the Times of Coronavirus, Information for Caregivers. That can be found on the link that was shared above by Carmen earlier on the EshelNet website. So it's available freely for you there. So at this point, we're going to be closing off. Dr. Maaravi, just to thank you again, to thank the Jewish Federation of Greater Los Angeles, and I'm going to hand over to you, Carmen.
And I just want to say, just as a farewell sentence, it's getting better all the time.
Thank you so much, Dr. Maaravi, and thank you all for joining us today. We're going to send a follow-up email to share a recording of the presentation. Dr. Maaravi, our gratitude to you for sharing your vast knowledge and really for your positive insight that you have in helping people age with dignity and also helping those who are caring for a loved one that has dementia. On behalf of Leah Phillips, who oversees the Health Services Division at the Jewish Federation, Mark Kodron from JDC Eshel, and myself, Carmen Tellez from the Jewish Federation of Caring for Jews in Need, we hope that you found this presentation and conversation valuable. We wish you all good health, and we look forward to seeing you again soon. Have a great day.
Bye-bye.
Bye-bye, everybody.
Bye-bye.